Good morning, good evening, or good afternoon, and welcome to this presentation on interprofessional communication. Today, I will be discussing the clinical, social, and professional aspects regarding interprofessional communication and some of the barriers that we face in these areas, not only as students, but as both novice and experienced practitioners, and finally, the room for growth and development in this area. Interprofessional communication is a multi-system and multi-team effort, and in our setting includes nurses, paramedics, doctors, social workers, nursing home staff, support workers, and many, many more. Described as the multi-perspective effort of sharing knowledge, expertise, and goals, it is an integral and fundamental part of our job as paramedics. A driving factor for myself in achieving good interprofessional communication is the reminder that these skills have the ability to significantly affect our patients' health and well-being and their future interactions within the healthcare system. Although it occurs in almost every context of our job, some of the most common moments for interprofessional communication can be found during clinical handover, pre-notification to hospital teams, or collaboration with out-of-hospital care services. This is also very much so not limited to the healthcare team, with interprofessional communication also taking place with police, fire, and search and rescue teams. This concept leads us into the clinical aspects of and barriers associated with good interprofessional communication in a healthcare setting. Although these concepts are definitely relevant to the interprofessional settings aforementioned, a large proportion of this presentation will focus on the importance and misconceptions of communication between paramedics and the hospital healthcare team. Interprofessional communication literature and discussions regarding healthcare collaboration have recently been centered around increasing skills in clinical handover between pre-hospital and hospital environments. This clinical handover has been proven to be an extremely important part of the patient experience, with research showing that clear clinical handover and interprofessional communication leads to increased patient safety and patient-centric care. On the other hand, errors and miscommunications during this process can pose a risk for patient safety. As recognized by researchers from the Global Patient Safety Collaborative in 2004, the primary objective of healthcare communication was the standardization of communications during clinical handovers and need for improving the handover process. With research showing that clear clinical handover improves patient safety, quality of care, and encourages a patient-centric approach, it is important that we strive to achieve clear and professional communication in these settings. This process, however, doesn't stop at verbal handover between clinicians. The use of patient-centered records is a fundamental part of the clinical handover process and is an extremely underutilized part of the paramedic job, with research finding as little as 49% of PCRs available to the clinician at the time of patient care. For those patients with PCRs, clinicians found useful information in 91% of cases, with 33% providing information that was considered to be significantly useful to hospital staff. As aforementioned, these errors could have significant consequences on patient safety, especially when considering drug administration, possible adverse events, patient allergies, and other pertinent information gained by paramedics. This lack of effective handover and communication may be due to the overall demeanour in which paramedics feel they require more uninterrupted time from hospital staff in order to effectively communicate. There are indeed many other barriers to this process, enough to write a PhD, as I'm sure somebody has, and hence cannot all be covered in a brief overview. When we think about the social aspects underpinning interprofessional communication, I like to think of all the non-clinical things that may affect both ourselves and our patients. As discussed, there are definitely barriers to the effective communication between hospital and pre-hospital teams. Much like I have experienced throughout my clinical placement, opinions may range from not feeling listened to by hospital staff or feeling that your work will not be looked at by treating clinicians. There are many factors to unpack. However, the aspect we will focus on today is much more centered on the patient end of social aspects of interprofessional communication. Paramedics are extremely privileged to be one of the most trusted professions in healthcare, with patients allowing us to enter their homes, workplaces, and personal lives. The information we are able to gain from this space allows us to investigate and communicate further with healthcare teams, leaving potential for additional needs of the patient to be met and risk factors that may affect their health identified. These out-of-hospital patient lifestyle factors are often termed the social determinants of health, which refers to the conditions of daily life, the circumstances in which people are born, grow, live, work, and age. A Canadian study highlighted this untapped potential to address the social determinants of health in our patients and the potential ability for us to assess the lives of these people and refer them to the service which they may require. Throughout my clinical placement experience, this social aspect of care and interprofessional communication has arguably been more essential than the clinical skills and interventions taught at university. The last 3 weeks of final placement have involved the communication and collaboration with services including in-home care, drug and alcohol rehabilitation teams, nursing home staff, housing assistants, and social workers. These experiences have led me to view interprofessional communication and collaboration, combined with the social determinants of health, as an opportunity to improve not only a person's health, but their well-being and lifestyle. All in all, the literature suggests that interprofessional communication is a fundamental part of our jobs as paramedics. So why do we do it? Well, the answer is we have to. The Australian Health Practitioner Regulation Agency, alongside the Paramedicine Board of Australia, formulated the professional standards and capabilities required of a paramedic. Of course, these include the knowledge and skills to treat a patient. But equally as important, they include communication. Domain 2 of the professional capabilities for registered paramedics includes the following. 1. Communicate clearly, sensitively, and effectively with the patient and other relevant people. And 2. Collaborate with other health practitioners. This includes both health professionals, volunteers, fire and emergency service personnel, or other registered health practitioners. One way to ensure this process is undertaken is the incorporation of interprofessional communication and interprofessional learning into the standard paramedic curriculum at universities. Studies like the one by Fursith et al. Highlighted the positive impact of interprofessional education amongst nursing and paramedic students and should definitely be a consideration for future course development. My first encounter with interprofessional healthcare communication commenced with my first day of clinical placement. Purely through trial and error and copious amounts of clinical feedback, this current clinical placement has seen a very large difference in my skills in communication. This all comes from a place of confidence in my practice, my abilities, and an understanding of the knowledge I have gained from my patient interaction in a unique perspective. So where does this leave me? How can I make sure I am positively contributing to effective communication in the healthcare setting? One way in which I will strive to achieve effective interprofessional communication will be the use of constructive clinical feedback by peers, mentors, and other healthcare teams. This feedback is an essential part of Kolb's theory of experiential learning, which involves the solidification of my learning experience by experience. With things such as communication, I'm very aware that my progression will take a lot of time and practice to maintain and develop. This clinical feedback and constructive criticism is also underpinned by a need for a good foundation of the knowledge of what constitutes clear and effective interprofessional communication. One way in which I plan on maintaining this knowledge is a commitment to extended and continued professional development, potentially branching out into extended education and research in these areas. I think one fundamental part of my progression as a clinician will be the attempt at inspiring others to achieve good communication by leading by example and ensuring I am practicing to not only the standard expected of me, but the standard that will achieve the best outcomes for my patient. This has been a huge learning point recently in my clinical placement, and I'm sure it will continue to be a learning point throughout my career as a young developing practitioner.